Well, good morning, everybody. First of all, we would like to thank Dental XP for this kind invitation. It's a really huge honor for both of us to be part of the XP family. In this presentation, we would like to explain you why and how the new digital tools can facilitate your daily workflow in implant dentistry. We've been involved since 4 years in the early development phases of the integrated treatment workflow. You will see we got a lot of material on this topic and we both hope you will like it. For those who want to know, our office is located in Paris, in France, as you can guess from our typical French accent. We're really lucky to work in a very nice location because our office is located between the Invalides, which contain Napoleon's tomb, and the Eiffel Tower, which is maybe the most famous French monument. And before starting this presentation, we would like to give credit to our team because we deeply believe in teamwork, and without them, we wouldn't be there to give you this presentation. We're really lucky to work with Dorothée Louis-Olszewski, who is a brilliant endodontist and the actual president of the French Endo Society, with Marwandas, who is a very famous prosto in France, and with Louis Toussaint, who is focusing on biomimetic restoration and is the editor-in-chief of the French Journal of Aesthetic Dentistry, published by Quintessence. So today, to meet your expectation, what we are going to say should follow some basic principles, just like in a recipe. First of all, it should be simple, because if this presentation is only targeted to a small number of people, I think that we are missing the main objective of this kind of platform. Then it should be aesthetic because nowadays aesthetic is everywhere, and most of all, it should be guided. And guided will be the key word for the next hour because if you want to be predictable in your daily practice, your implantology has definitely to be guided.
Yes, Karim. Hi, everyone. Guided because our goal in implant dentistry is to control the logistic chain of treatment from planning the surgery to delivery of the final prosthesis. As we will see in this presentation, many factors are involved that can influence the final result. But today, we are going to focus specifically on the importance of guided surgery and on the tools that we have to facilitate our workflow.
So today, and I think we will all agree on that, we are facing a lot of implant failure. For example, in our office, 30% of the initial consultation are just for managing implant complication. And of course, failure is always the association of different factors. But believe me, there's one thing that is really common to all the situations, that usually the failing implant is always positioned in the wrong way. Just like in a case like that, where you can see that I think at the initial situation you got everything to do a success, you got soft tissue, you got bone, and just because an implant is positioned too far buccal, the situation will be transformed into a real nightmare because very often if you want to solve this kind of case, you have to remove the implant. That's the only way, and that's a real nightmare for you, that's a real nightmare for the reference, and that's a real nightmare for the patient. So let's say a quick word about periimplantitis. Of course, periimplantitis is a very complex and multifactorial disease, and we are not here with Leon to go too deep into details because it's clearly not the main focus of this presentation. But what is interesting if you look at the etiology of periimplantitis is that just after all the bone loss related to biofilm, and I think that the main question would be, was biofilm there first, or is there something that brings the biofilm on site? The second top ranked factors are just iatrogenic factors. That's a really interesting fact because I think that we have a direct influence of this factor. I'm really convinced that by avoiding some basic mistake, we can really get all better results in our everyday practice. And what is more interesting if you go a little bit further into details is that poor implant positioning is by far the most common local factor that will lead to bone loss. In more than 40% of cases, the peri-implant disease begins just with an implant that is positioned too far buccal, creating buccal bone resorption, leading to rough surface exposure and permitting the colonization of the surface with the biofilm. So once again, everything is about biology, and now I'm sure that you see the point. And if you look at the number, I think it's 1.3 or 1.4 implants per case, so single implant is really the most common procedure that you will have to face, whether you're in an advanced practice or not. So, to succeed, you better have to learn how to do it right. And implant 3D positioning is crucial if you want to end with a long-term predictable result.
Of course, three-dimensional implant placement is not only a critical factor for implant survival, but it also influences the shape of the future restoration as well as the soft and hard tissue contour. Stating that implant position should be prosthetically driven is obvious, but it's not enough. It's essential to assess the size of the tooth to replace and to relate it to the diameter of the implant, the type of implant that we are using, and the features of its connection, as well as to visualize the future emergence profile. All of this is very nice in theory, but how can we transfer this virtual planning to the clinical reality to obtain a clinical success? Let's talk about guided surgery and let's see what it can do for us.
So today we are surrounded by digital technologies. I think you all noticed that. You're all aware of that. And our goal simply with Neon today with this presentation is just to help you, to make you step into this running train that is evolving so fast and to welcome you into the digital world. I've been using guided surgery for more than 15 years now. And you know, guided surgery has known a real revolution very recently that just few people noticed. The revolution is that you can now merge the data from a lab scan to the DICOM file of your patient. It doesn't seem to be a big deal, just if I told you that like that, but believe me, this is a real game-changing process because we can now produce teeth-supported surgical guides that will fit perfectly for all your single and partial cases. Clearly, you can forget about all the other way to get a surgical guide because it's the most accurate way to do it. And when I'm talking about accuracy, when I'm talking about perfect fit, I'm talking in microns here. I'm sure that you're all aware of the outstanding result that you get with desktop scanner. It's clearly the best way to get data for digitalization of your patient. And this merging process is a real easy process called Smart Fusion. You just need 4 reference points and the algorithm will do the rest. It will lead you into a 3D environment where you can plan very easily your implant position according to your prosthetic need. And then you just have to click on one button to receive your surgical template that once again will fit perfectly with the clinical situation. And this surgical guide could be a pilot drill template if you only want to go for a 2mm drill procedure. It could be a fully guided template if you want to go for a fully guided procedure. Or it can be a combination of both if you get specific issues, for example. So Leon, just to be sure that we're crystal clear on this topic, can you just summarize this process for me, please?
Sure, let's see this case where we have this 33 years old patient who presents in consultation with an external resorption on tooth number 11. As you can see on the clinical picture, apart from gingival inflammation, our goal should be to preserve the gingival contour as much as possible, and specifically the papilla distal to the number 11, which seems to have already diminished. Immediate implant placement and provisionalization is a seducing protocol since we know from the literature that when properly indicated and executed, it allows to preserve properly the gingival contour. Looking at our checklist for immediate implant placement, we see that the teeth positions are correct, the gingival contour is satisfactory, there is no need for regeneration, we just want preservation. The buccal plate which will ensure proper bone healing is present, and the root position in the sagittal plane allows for prosthetically driven implant placement with sufficient primary stability. And last but not least, the occlusion of the patient allows for temporization without any occlusal contact static or dynamic. And this is a typical case where the use of a surgical guide helps to be more predictable. We are going to build a surgical guide using the same technique that Karim showed a few minutes ago. And we are going to obtain with this technique a surgical guide that is only teeth supported and is therefore very precise. And in case of any doubt, it's very easy to remove and reposition it to make sure that we are drilling where we want. The payload drill gives a perfect control of the surgery and of the deviations that can happen because of different bone density, and we can obtain a very good primary stability and we are able to provide a provisional on the same day for this patient. As you can see, we have a very good healing, and with the final prosthesis, the result is satisfactory. The gingival contour is perfectly preserved.
We're going to see this slide at different point of the presentation. The slide is just a quick reminder to summarize where we are with our solution. And it's also an easy way to see how digital your workflow is. What you should look at is the interaction between the analogic and the digital world. You should look at what we call the traffic jams, because that's the real way to see exactly how digitally advanced is your workflow. And what you can see here is that with the integrated treatment workflow, we have made some improvement, but we are clearly not still fully digital. But before seeing this kind of workflow, so let's say a quick word about precision. And to talk about precision, we have selected this clinical case, which is interesting to my opinion because this is a really challenging case. This is a conventional one. This is a freehand surgery. You see, in this case, despite a major apical lesion, we decided to go to immediate implant placement just because of the persistence of very thin buccal plate. You see that the surgical procedure that we have chosen is almost the same that for an endodontic microsurgery, and that the implant that is placed is just anchored in the remaining bone above the lesion. You can see that the implant placement is correct. The implant position is okay in the 3 dimension of the space, and that it will lead to a good aesthetic outcome, because you see the picture 1 year down the road after the surgical procedure at the crown placement, we got a very nice aesthetic outcome. But we are showing you this case not to tell you, of course, that in this kind of complex situation, you or we can achieve good result, because that's true. We can all treat cases like that and obtain good result. But the real question beneath this kind of case is, can we achieve predictable result in every situation, every day, after every day, every week, depending on the situation, on the patient, on your condition, because we are just human being. And to be really honest, if I'm asking myself this question, the answer is no. I cannot be so predictable. And I want you to consider the guided surgery just as an additional tool to enhance your daily practice, to make you more predictable in your everyday practice. So to take another example about precision, if you're in a good mood or if you have good skills, it could be easy for you to reach the center of the target, but for one shot. But you can see that if you try again and again and again, it will become more difficult for you to put the arrow in the same position. And if you look at this guy on the slide that beat the world record in the last Olympic game, you can see that these shots are clean shots, but that's definitely not the kind of predictability that we want for our anterior restoration. Definitely what we want is the Robin Hood kind of predictability, because what we want is to put the arrow into the arrow, and we want to do it every time. And that's exactly what guided surgery will provide you on your daily practice, on a daily basis. I also want you to understand that we are not just here to show you some beautiful case report and that's all. Because for Leon and I, guided surgery is really a daily procedure. It's a real revolution, because once you start your surgery, you know that you got a GPS. You got your surgical template that you can truly rely on. This is important if your only job is to place implant, like us, but it's also important if you're a GP, and that you have to perform many different procedures in the same day. You can be sure that with guided surgery, every day will be a good day, and this is the most important thing. But we also did some research on this topic, and we want to share it with you, Leon.
Yes, Karim. Feuerhauser published last year a research article where he looked at the association between three-dimensional accuracy and the pink aesthetic score. What he concluded was that accurate implant positioning may increase the predictability of obtaining a favorable emergence profile and soft tissue aesthetics. And that's very interesting. And what we did is somewhat similar. We measured the pink aesthetic score before and after immediate implant placement using guided surgery. What we found was that out of 22 patients and 33 implants, the pink aesthetic score was stable over a 1-year period. We observed a loss of papilla height, which is normal after any extraction procedure, but we had improved gingival texture. And the full results will soon be available.
We also did an observational study based on our operative reports. Only 2 investigators, Leon and I, 142 patients, 148 surgical templates, and 269 implants with conical connection, either tapered or parallel wall. And the first interesting fact that we want to share with you is that our indication remained the same. We didn't add more indication with guided surgery. Basically, we use this workflow in all situations where we were using a conventional surgical guide. So you can say that we just switched from an analogic workflow to a digital one. Look at all the situations. Implant in the aesthetic area, of course, we were using before a conventional surgical guide. Immediate implant placement, you need to know about the prosthetic outcome, so you need a conventional surgical guide. Graftless approach, where you are playing with the bone volume of the patient, you have to see where your implant's going to end. More than 2 implants to place, you need 3D information. You need a conventional surgical guide. And the last situation is the more obvious. When you graft at the same time of the implant placement, you need to know more about the prosthetic outcome to know where your implant's going to end according to this prosthetic outcome. So you need a conventional surgical guide. And in all these situations, we just switch. And here is why we switch. If you look at the graph here, we gave a nod between 0 and 10 to the fit of the guide and precision of the procedure. And look at the number, look at the result. These are really huge results because we're talking about 269 implants. And to me, it was not surprising because this is the first time that we use a desktop scanner to do the acquisition for the data of your patient. And the merging with the CBCT diagram file of the patient was also really accurate procedure. So the whole procedure that we get, the fit of the guide is perfect and the procedure is really accurate. And let me just show you a video here when we use the new WP parallel CC to replace a first upper right molar. As you can see, it was just a pilot drill template, and many people are saying that this is the worst in precision when you talk about guided surgery, the pilot drill template, and look at the result. Look at what you see. What you can see is just the screw hole of the healing abutment through the pilot drill sleeve. This is amazing result, but believe me, this is daily practice with this workflow. So the next question for us was, at the stage of the development of the integrated treatment workflow, it was just clearly, can we go further? Can we treat larger fading dentition? Can we go to full fading dentition? And until now, to do so and to treat this kind of patient, we have to go through a double scan process to create a specific radiographic guide and to modify it between the two acquisitions. It was really a technique sensitive protocol from the clinical perspective and from the lab perspective also. So it was really a tricky procedure and not a procedure for everyone. And that's exactly why with my colleague Leon and Marwan, we have developed what we call the strategic extraction protocol. That is a more precise and a more easy to use procedure on a daily basis for everybody.
This strategic extraction protocol comes from the fact that we want to have a teeth-only supported surgical guide. But in some situations where there are many teeth that needs to be removed, we will have rocking and unbalanced issues, and we want to keep specific hopeless teeth as abutment to stabilize the surgical guide. These hopeless teeth will be removed at the end of the surgery. So let's look at this surgical case here, where we need to remove all the teeth marked in red, and we'll keep the teeth marked in green. It's easy to understand that if we only stabilize our guide on the teeth marked in green, we will have rocking and unbalanced issue. What we do here is we're going to select in advance the implant sites and the pontic sites and keep specific teeth that will be not in the way of our implant positioning. When we look at the surgery here, you have the planification that is on the left, where you see the model that is in red and the wax up that is in blue. You can see that that's what we use to plan for implant placement. And we can go forward and proceed with the surgery in a very precise manner because we kept the two lateral incisors of the patient to stabilize anteriorly our surgical guide. So the fit is perfect. It's always, as always, teeth supported, and it allows us to place the implant exactly in the position that was planned. And on the same day, we'll provide this patient with an immediate provisional, and 3 months later after healing, a final bridge. Here, a Procera full zirconia bridge. That gives a nice smile to the patient.
And what about immediate implant placement and full arch reconstruction? Well, it's almost the same thing. Here you are in the lab software interface, the old version of the software. You can see that we have scanned all the failing dentition of the patient. We take it as a model. If the failing dentition of the patient doesn't fit, you can do a wax up, you can try it in a mock-up, and then you can scan it. Then we cut all the teeth involved with the implant site and we scan it again. With these two acquisitions, we can superimpose them, we can merge them to the CBCT files of the patient, just like we were showing you before. We can do the planning the same way, very precise, very accurate procedure. And then we just have to click on one button to get the surgical template. And this surgical template will perfectly fit to the clinical situation once you extracted the teeth that are located in the implant site. Look at the procedure. This is a really easy to use procedure because you can remove the surgical guide at any step. Watch what you are doing. You can put the implant, do the drilling, everything. And once the procedure, the guided procedure is finished, you just have to extract your remaining teeth, do your dual zone technique to preserve your soft tissue and the bone or anything you want if you want to use a different procedure. And then you can go for the provisional. And here is the result with the provisional after 4 months of healing. Then we just finish the case with a conventional PFM bridge. This bridge has been done by a lab in Saint-Tropez, which is very famous in France, called Esthétique Orale. And look at the patient. This is a real happy patient. And this procedure is a real straightforward procedure, very precise, very easy to use on a daily basis. And if you combine it with provisional implant, I can tell you that you can treat almost all your cases like that. So you can almost forget about dual scan process because integrated workflow will truly allow you to treat almost all the situation. And here is where we were with the integrated workflow. You already seen the slide in the presentation before. You see with the integrated treatment workflow, we did some major improvement, but we need still to have some changes in our workflow to be fully digital and to go more to the digital world. And that's important because for us, clearly, the future, the next step is clearly to go fully digital. And what we want to show you in the second part of the presentation is to share with you this new approach, this new fully digital workflow. This new fully digital workflow means that in only two appointments, and 4 clinical steps, you can solve almost any patient situation. And remember, the first thing, the less step you will do, the less mistake you will do. This is very important. If you look at this first slide, you see that the full digital workflow will bring a real advantage to your patient if you talk about potential cumulative errors between the different workflows, because you got very, very few steps. So less mistakes, less clinical step. We can clearly say that the fully digital workflow is the most straightforward procedure that we ever had for implant dentistry.
Yes, and going fully digital should not be seen as a fancy trend to promote our activity or practice. It is something that is going to change the way we work and the way the patient feels. From their point of view, as you can see in the video, the first revolution is that we get rid of the alginate impression. It was seen by clinicians as an easy step, but it was rarely done on first consultation as it could be perceived as an invasive procedure by the patient. With digital impression, things are different. The procedure is easy as getting an X-ray and it is not invasive at all. Very often it's the first time that the patient gets to see this kind of device. Look at their first reaction when they turn their head and look at what is going on. They can get a sense of what is digital impression. And now we are going to be able to integrate this digital impression into our workflow to plan for the next steps in our treatment plan.
So basically, what's this fully digital workflow? The first thing is that we can now merge STL file from the digital impression to the DICOM file of your patient, just as it was the STL file from the lab scan that we done before. But if you look carefully, there's a real novelty. You can also now import the occlusion of your patient. You can import the antagonist. And you can use it to create what we call a smart setup. This is really the first time that the Nobel Clinician software, the surgical software, is connected with the Nobel Design, which is the lab software. And we can now use them to produce a surgical template and a provisional with the same file. Believe me, this is a real revolution because the perspectives of these two software working together are awesome. You will see in the presentation you can modify in the surgical software the smart setup if the first one was not smart enough for you, and more if you want to do some fine tuning or if you want to go for a provisional, you can ask for lab design to your lab and you will be able to import it into the surgical software. I know that you're all aware of the DSD. You know the real strength of DSD is just to have the final result in mind just before starting your case. And here it's exactly the same thing. For once, you can be sure that the implant you plan will perfectly fit to the final situation at the first step of the treatment. That's a real revolution from a surgical standpoint.
Okay, so to give you an overview of where we are now, let's jump into the management of clinical cases. The first one is a young patient coming because there is something weird with his central incisor. As you can see on the X-ray here, there is a massive root resorption on root number 21, and this is a good case for our workflow. We start by taking a digital impression and a cone beam CT on the first consultation, and then we can merge the obtained file into our software to be able to plan the case and obtain a surgical guide as well as a provisional thumb shell. So first appointment consultation, second appointment is going to be the surgery. Alright, so in the planning software, well, just this way we pick the DICOM file and we merge it to the STL file obtained from our intraoral scanner. Just a quick reminder, DICOM files are issued from the CBCT and STL file is issued from the intraoral scanner. We give some reference point, merge the files, import also the antagonist, and then we are going to ask the planning software to build a WAXUP for us. This WAXUP is called here a smart setup, and this is what you can see in green. And the beauty of it is that in the planning software, we are able to modify what the proposition of the computer was. Here you can see here, we can move it. We can add some small rotation, and this is particularly useful in this case where we have slight rotation of the teeth. You can see here occlusally. And this way we have everything we need to plan for our future implant position. And this is very important because right now we are preparing for the surgery, and it's important to place the implant exactly where we want in terms of emergence profile, in terms of we want to have a screw access that is palatally, of course. We want to use the most of the bone volume to be able to achieve good primary stability. So it's very important to take some time at this point of the planning. And then we ask for guide. And this is the surgical guide that we are going to obtain. And you can see here the planification. We will see that with the next case, but from this stage we can ask also the software to build for us what we call a temp shell. Is going to be a shell that we are going to reline to build a provisional on the same day. And this is what you can see here on the left side. I won't go into much details more for this case, but this case we go do the surgery, extract the tooth atraumatically, use the surgical guide to drill and place our implants, and then we can use the temp shell and give this patient on the same day a provisional that looks exactly what we wanted it to look. All right, so let's look at another case here. This young lady comes because after she finishes her ortho treatment, it was discovered that she has root resorption also on tooth number 23. And you can see that here. It's a massive root resorption, but luckily for her, it's really localized palatally. So the whole bone buccally is preserved, the buccal plate is totally preserved. So we can look into extraction and immediate implant placement. As you can see, to do that freehand is very tricky because there is a very limited bone volume apically to the root. So we want to do that and to perform this surgery guided. All right. So first, the first steps are exactly the same as the one that I showed you with the previous case. We are going to do an intraoral impression. We are going to merge those files with the files from the cone beam CT. And we are going to plan for our implant position and obtain a surgical guide. And here we are at this stage in the software. What we can do at this stage when we have this surgical guide is that we can jump to another software that is called Nobel Design. And in Nobel Design here, we are able to modify further the smart setup, the wax up, and here to modify it very precisely to build exactly the future crown, the temporary crown that we want for this patient. And that's what we're going to do, and we are going to add some wings on the sides, and those wings are going to help us to stabilize the temp shell on the adjacent teeth in the perfect position. And then we get everything delivered in the office and we are ready for the surgery. In this case, we just remove the tooth, and as you can see, very localized lesion in palatal, very big lesion, but still we are able to remove the tooth atraumatically, and this is very important to preserve all the structures around, no flap in this case. And here we go with the surgery. Use the surgical guide, do our drilling, place our implant, Nobel active implant, very important here to obtain good primary stability with very small amount of bone. You can see here occlusally the position of our implant. We have a gap buccally that we're going to fill with a xenograph according to the dual zone technique. You will see that later. And here we are trying on our temp shell. You can see it's PMMA, and the adaptation with the wings is very nice. That way we can position it exactly the way we want. If there is some trimming that needs to be done, it's the stage to do the trimming to fit it perfectly. Then we put a small rubber dam around the abutment, place the temp shell again and reline it. We capture it, and you can see here we used an implant as a replica, but you can see here from left to right we are going to add acrylic to manage the emergence profile as we like. We add the xenograph material, and here we are ready to introduce our temp shell. And this is how the patient left on the day of the surgery. You can see that it's very satisfactory. We finished the crown afterwards, and this is a full zirconia crown that that has ceramic veneer layered on it. With angulated screw channel to manage exactly the screw channel in palatal, but that's another topic. And you can see here the final result. And we have a very happy patient with a very simple workflow and very predictable workflow also. And that's the whole point of this workflow. It's to be able to be predictable, really quick, and to be able to, in one consultation, being able to plan for surgery and for provisional restoration. And here we are with another patient that suffered from trauma when she was younger. She got many problems on those two central incisors, and now we are at a point that we cannot restore it anymore with conventional fixed prosthodontics, and we have to remove them and place implants. So same steps, we're going to take an intraoral impression, take a CBCT, merge those files, and build two things: a surgical guide and a temporary shell that is going to be a reposition with wings on the side on the adjacent teeth. Here you can see the two implants position. In this case, we redid also the endo on tooth number 22. And here we are, ready to go for our surgery. There's plenty of bone to stabilize our implant, and we can go. When we receive in the office, that's what we receive. We receive on the left the surgical guide with the two sleeves to place our implant and to do our drilling. And on the right, you can see the two temporary shells. I mean, actually, it's one block with two wings to reposition it correctly. And then we can jump to the surgery and remove those teeth atraumatically, as you can see here on those pictures. And here we are, those two teeth are removed. As you can see, everything is preserved, and we can go and deal with our surgery. We look at the buccal plate position, and you can see it's very well preserved here. No flap is going to be elevated. We place our surgical guide and go for drilling sequence. It's very important to point that this type of guide is very useful because since it's built on the teeth and it's only teeth supported, it's very stable, but also we can remove it and check that we are drilling in the correct axis and position. So it's not a blindfolded surgery. Like, we're not just drilling in the blind, placing our implants in the blind. We're looking at what we are doing, and it's a very nice surgery to perform. Here we are with our two implants placed in position, and now at this stage we are ready for provisionalization. We place our two temporary abutments, occlusal view, and we try on our temp shell. And you can see here we trimmed a little bit the palatal part because it was difficult to fit it correctly here. And we are going to add acrylic to that to capture the temp shell with our abutments. And we are ready on the lab to prepare our temporaries. Here we go with the same procedure you've seen, placing two healing abutments to be able to place our grafting material all the way to the gingival margin. And here we are here. You can see how nice it looks and how bulky it looks into these occlusal views. And then we place our two temporary crowns. After healing, we have nice healing, nice soft tissue contour, and here we are with the occlusal view and the frontal view, and this case is now ready to be restored.
So let's try to summarize the prosthetic procedure with another clinical case. Here we got a failing lateral incisor that has to be extracted. We refer the patient to the endo, but the tooth is cracked and we have to go through an immediate implant procedure. So we did exactly all the same things that for the other situation. We merged the STL file of the digital impression of your patient to its CBCT diagram file. And in this case, we ask for a specific lab design. Instead of choosing the tooth in the library form, we ask for something that we call biocopy of the contralateral tooth. Biocopy is a real interesting feature because it allows you to copy the right shape, texture, surface of tooth and to paste it on the surgical side. It's really an easy way to get a temp shell that will allow you very easily to get a natural result. And here is just how we are using the temp shell right after extraction and implant placement, and you can see all the clinical steps all on the screen. So let's take a look at all these steps. We are just positioning the temp shell on the surgical site with the help of a twing. You can see that it fits perfectly to the situation. Then we just have to put the temp abutment, and at this stage it's important that you must be very careful of any bony interferences, and that's why we are using a Trifine to ensure us that this abutment is correctly seated. My personal recommendation will be to take an X-ray at this stage. And even if you can just snap this abutment, to my opinion, it's better to screw it and to avoid any time consuming mistake at this stage. Then we use a piece of rubber dam, you see that, to isolate the surgical site, and we use multi-link to link the abutment to the temp shell. Your goal here is only to capture the abutment position with the temp shell. All the other modification for the emergence profile will be made extraorally. So here is the result after the connection between the abutment and the temp shell. You see that we remove it. All the other modification will be made extraordinarily, and here is the result once the modification have been made. You see we got a provisional that perfectly fit to the surgical site, and because of the biocopy feature that we use in this case, the aesthetic outcome is really great, even with a standard MILP MMA material. And look at the patient after only 1 week of healing. We clearly got a nice integration. And here is the same result from a different angle. Once again, we got an happy patient just because of this straightforward procedure. So here we are once again with a slide that compares different surgical workflows in implant dentistry. And for once, I think that the slide just speaks for itself, because with the fully digital workflow, you can see that we are clearly more efficient because between our two clinical steps, everything is just done in the digital world. So once again, at this stage of development of the fully digital workflow, the question was for us, can we go further? Can we treat larger cases with the kind of protocol? And to answer this question, let me introduce you Charlene. I'm not really a huge fan of the clinicians that use their patient name to their presentation to just to give them more effect. But this case is really special for all our team. Charlene just came at her initial consultation after an auto treatment. You see that she has undergone also a maxillofacial surgery. And as you can see, she got 2 full arch provisional restoration. And a dentist just referred her to a practice because after all these steps of treatment, he doesn't clearly really know how to manage the end of treatment of Charlene. As you can see, she's got multiple failing temporary teeth associated with severe bone atrophy in the maxilla and in the mandible, so implants are clearly not possible without preliminary bone grafting. You can also see that we got some issue with the orthodontic treatment because space management was not so correct. So this case is a real challenging case with a very sweet young lady, but she's really also traumatized by all her previous dental treatment. So she's really not a piece of cake. She's a tough cookie, and she's really not easy to manage. So in this case, like all other, our approach is always the same. Like I said before, we will start the case with the final result in mind. That's why we did new provisional that just fit better to the situation and to the patient expectation. By doing so, every step that we're going to need to get this result is accepted more favorably by the patient. Another advantage of this procedure is that she became confident in her treatment and that now she's feeling comfortable with us. Because of the two-stage bone grafting procedure that she has to go through, the maxilla was the first jaw that we finished. We did it using the conventional integrated workflow at this time because we didn't have the full digital workflow at this time. And you can see that because of the space limitation that we get in this case, this procedure was really very useful to get a nice aesthetic outcome. For the lower jaw, we decided to go and to use the strategic extraction protocol, but to do it fully digital. Fully digital means that in this situation, like in all the situations that we showed you before, we will need just 2 single appointments to solve the patient case. So here you can see on the screen the first digital impression that we used to start the case. And we did everything exactly like we told you before. The main goal of this procedure, I remind you, is to keep some hopeless teeth as abutment for the surgical template. So in this case, we decided to keep the 2 permanent teeth and to go for 8 implants to be as close as possible of a natural dentition. I wouldn't do that in any other case, but it was really important for Charlene keep her permanent teeth. And we selected also the two central mandibular that will be kept during the surgery, and then after be replaced by two pontics. It will be the only pontics that she's gonna have at the end of the procedure. Once again, remember that until now we just have one clinical step and all the modifications have been done digitally. Let's take a quick overview of all the procedure. First, we import the CBCT DICOM file of the patient. You can see the bone grafting on the bony model. Then these data are merged to the digital impression with only 4 references. In cases like that, with small number of references, I urge you to check the accuracy of the fusion before going any further. In this case, the software was not able to produce a smart setup. That's normal because it's not the right parameter for doing so. So we asked directly for lab design. Once again, because all the spaces limitation of this case, it's really important to be able to do your planning with something that will be as close as possible of the final result. You can see in the Nobel design software that the lab design was done very, very efficiently according to the patient occlusion, according to the situation, according to all the spaces limitation. We can check the occlusion, we can check many things, we can even have a virtual articulator, but that's not the topic of the presentation. What I want to highlight is that it's really important to be able to do your planning with something that will be as close as possible of the final result. Then, once you're satisfied with your lab design, you have checked it with your technician, you can import it again in the surgical software, and then you can do your planning. And once again, your planning will be done according to what the patient will have in the mouth at the end of the treatment. That's really important. Once you have done your planning, you just have to click on one button, and then you can produce a surgical template that will fit to your surgical situation. Then you get a surgical template that you can put in the mouth of your patient. Of course, after all the strategic extraction have been made, you can see that we are unscrewing all the bone, the screw that holding the bone graft. Of course, guided surgery doesn't mean flapless surgery. That's a common mistake. For me, with conical connection implant, I think it's really important to assess and to check where you're going to end with your implant platform to reestablish a correct biology Swiss, especially in cases with thin biotype. You know that you can put your platform equicrystally, subcrystally, and that the remodeling, the bone remodeling, depends a lot on implant position. Then we use a trifine to remove the bony interferences. This is very classical, very conventional. What you can see that we get a nice result in terms of precision with this procedure. Once again, we put multi-unit abutment. We just, like in all the case, use the dual zone protocol that has been well described by Denis Tarnow, all his team, and even Salama in Atlanta. We suture it, and that's all. The surgical case is done. We tried to keep as digital as possible. To be very honest, today digital impression for full arch restoration doesn't work very well. We have tried it many times and we're really not satisfied by the accuracy of the procedure. But once we take a conventional impression with plaster in this case and silicone too for the two remaining teeth, we switch once again directly into the digital world. And what is cool here is that we are able to use the template that has been produced in the lab design to superimpose it in the software that will be able to do the provisional. We can put it on the model. You can see that the surgical planning was correct because the implant position are really the same that what we are planning. And then we just have to click on one button in the lab and mill the restoration. You can mill the provision that will be screw retained, but we can mill also the two provisional crown that will be put on the permanent teeth. Here is a quick overview of Charlen's treatment. You can see the full arch with the remaining teeth. You can see the strategic extraction. You can see the surgical template in place. You can see the implant at the end of the procedure, and of course the temporary prosthesis that was fully seated on the multi-unit abutment. But what is more important, in my opinion, is the amazing result that we can provide to a patient today. Clearly, digital tools have completely changed the way we are practicing implant dentistry, because if you look at challenging situations like this one, you can see that guided surgery allows you to get better and predictable results in just fewer clinical steps. And it's really easier today to turn a traumatized patient, just like Charlene, into a beautiful and happy young lady that is now fully confident in her future. And that's exactly what I want you to keep in mind at the end of the presentation. I would like to thank you a lot for your kind attention. And now, Leon, maybe you have some few words to conclude this presentation.
Yes, Karim, thank you all for watching this video on Dental XP, and in conclusion, we hope we could give you a glance of what is possible today with guided surgery and immediate provisionalization. We are surrounded by digital technologies and improvements are coming every year. The beauty of this field is that it's constantly evolving and we should all be excited with what is coming next. There will be more tools to improve our treatment's efficiency and our patient's experience. Thank you again for watching this video. Hope you enjoyed it. Feel free to come and meet us in Paris. You're always welcome. You can follow us on Instagram for more content, updates, and to see us opening French wines, of course. Thank you, Dental XP.